Hi, everyone. Welcome back. Today, we're going to cover Chapter 13 in our Neuroscience Fundamentals for Rehabilitation book by Lundy-Ekman. Today's going to be a deep dive into our lower motor neurons and spinal motor function. So basically, how the nervous system turns a decision to move into muscle contraction and what changes when the system is damaged. I'll start with how voluntary movement is controlled, cover how the muscles contract and what muscle tone is, how the spinal cord coordinates movements and reflexes, and then finally the clinical signs and tests used to localize lower motor neuron injury. So movement begins in the brain, primarily in the frontal lobe. Once a movement is planned, upper motor neurons will send signals down the spinal cord. Two major control systems will help refine that movement. You have the cerebellum, which coordinates timing and accuracy, and the basal ganglia, which help select and initiate movement patterns. Upper motor neurons synapse on spinal interneurons and lower motor neurons. Lower motor neurons then will send signals directly to skeletal muscle, so they are the final common pathway for voluntary movement. Inside each muscle fiber are myofibrils made of repeating sarcomeres. Sarcomeres contain actin and myosin filaments, and contraction occurs when myosin pulls on the actin. A nerve will signal a release of calcium inside the muscle fiber. Calcium exposes binding sites on the actin, so myosin can attach, pull, and detach repeatedly. This process is called the cross-bridge cycle, and it's what generates muscle force. So contraction isn't going to be just a single event, it's millions of microscopic interactions happening at once. Muscle tone is the resistance of a resting muscle to passive stretch. This tone comes from multiple sources. You have elastic elements like titin and connective tissue, weak actin myosin attachments, and ongoing neural input from the spinal cord and the brain. Clinically, we assess tone by passively moving a relaxed limb and feeling how much resistance is present. There are two main types of lower motor neurons. You have alpha motor neurons, which activate force-producing muscle fibers, and gamma motor neurons, which adjust muscle spindle sensitivity. Alpha and gamma neurons usually fire together, so the muscle spindle stays sensitive even when the muscle shortens. A motor unit is one alpha motor neuron and all the muscle fibers it innervates. Motor units are recruited in a predictable order from small, fatigue resistance units to large, powerful ones. This is called Henneman's size principle. The spinal cord does more than just relay signals, it can also help organize movement. Key mechanisms in the spinal cord include reciprocal inhibition, muscle synergies, and stepping pattern generators. With reciprocal inhibition, this is where activating one muscle group will inhibit the antagonist. So you're moving one muscle group and your muscle spindles are sending information back to the spinal cord to inhibit the antagonist muscle group to move. Muscle synergies are going to be when a group of muscles are activated together for a functional pattern. An example of that would be when you're trying to supinate your hand, your elbow may reflexively bend and your fingers may reflexively bend as well to help generate a movement pattern. Stepping pattern generators are going to be a network of spinal interneurons that help produce rhythmic walking movements. So it helps coordinates your hips, knees, and ankles to flex and extend within the stepping gait pattern simultaneously. Walking is partly automated by spinal control, but it obviously is still heavily modulated in the brain. Reflexes provide rapid automatic responses. A stretch reflex is going to be a quick muscle stretch that triggers a contraction of that same muscle. This is something that happens when you have a stimulus where maybe a tendon is being tapped and that reflex is going to go back to the spinal cord and tell that same muscle to move. So when you have a reflex hammer, you'll see this stretch reflex happen. You also have a withdrawal reflex, and this is what happens when painful stimuli activates multiple spinal segments to flex the limb away. For example, one foot is placed on a sharp tack, and then it's going to activate the opposite limb to straighten up to help carry the weight and reflex that pained limb away. It's a postsynaptic reflex and involves coordinated activity across several muscle groups. So obviously these reflexes can operate without brain input, which makes them useful for clinical localization. Now let's talk about contractures versus contractions. A contraction is an active force production by a muscle. A contracture is a long-term structural shortening of the muscle and connective tissue that limits range of motion. So again, contractions, moving that muscle, we're voluntarily moving that muscle. A contracture is something that happens when there's damage there. So if a muscle is immobilized in a shortened position, it will lose sarcomeres and connective tissue stiffens. If immobilized in a lengthened position, it will add sarcomeres. These structural changes explain why prolonged positioning can permanently affect joint mobility. When considering involuntary muscle activity, some involuntary contractions can be benign, like cramps or the occasional fasciculations. Others are always abnormal. Fibrillations, which occur in denervated muscles, are not visible on the skin. And you have tremors, which can be restful, postural, or intention tremors that have different neurological causes. Understanding these patterns can help localize neurological dysfunction. So what are some signs of lower motor neuron lesions? When lower motor neurons are damaged, muscles lose their direct neural input. Classic signs include weakness or paralysis, muscle atrophy, decreased or absent reflexes, hypotonia or flaccidity, fibrillations. These features help distinguish lower motor neurons lesions from upper motor neuron lesions. Two main tools that are used to evaluate these motor neuron disorders are nerve conduction studies and EMGs, or electromyographies. Nerve conduction studies measure how fast electrical signals travel through the nerves and help identify nerve versus muscle problems. Electromyography, or EMG records, record electrical activity in the muscle, often with a needle electrode. So an EMG can help differentiate between denervation, reinnervation, or primary muscle disease or myopathy. Different patterns of electrical activity can help localize where the pathology is occurring. Now we can discuss motor neuron disorders and polio. Lower motor neurons can be damaged by trauma, infection, degeneration, tumors, or vascular disease. Polio is going to be a classic example. It destroys anterior horn cells. Surviving neurons can then sprout new branches to reinnervate muscle fibers, but these enlarged motor units may eventually fail. This leads to something called post-polio syndrome, with new weakness, fatigue, and pain years after the initial illness. So to wrap it all up, lower motor neurons are the final pathway from the nervous system to the muscle. Spinal circuits coordinate movement and reflexes, while muscle structure and neural input determines tone and strength. When lower motor neurons are damaged, muscles become weak, atrophic, flaccid, and lose reflexes. And electrodiagnostic testing can help confirm where the lesion is. That's what we have for this podcast. Thanks for listening.